Yeah. Welcome you all for the Vijaya Diagnostic Center Diagnostic Education webinar series. Vijaya Diagnostic Center is conducting this VDC webinar series in regular intervals on various topics of clinical interest. Here, there would be a clinical speaker from that particular branch, and a radiologist will be presenting a PowerPoint presentation related to the particular topic. So today's topic is regarding the current trends in radiological diagnosis related to rheumatoid arthritis. We have with us our chief guest to this evening, Dr. Chandra Mouli, sir. Sir is chief rheumatologist and director of rheumatology at Krishna Institute of Medical Sciences, Minister Road, Hyderabad, and has extensive experience related to rheumatological disorders and has a vast patient clientele from different parts of the country. And I'm very fortunate that I'm closely related to the imaging diagnosis of Dr. Sarath's patients. With us today, the guest speaker today is Dr. Pallavi More. She is a senior consultant radiologist at Vijaya Diagnostic Center Group and has done her PG from Breach Candy Hospital, Mumbai, and has experience of about 10 years. First, I would like to invite Dr. Chandra Mouli to give us some clinical inputs and how the imaging is helpful in rheumatological disorders. Over to you, sir.
Hi, good evening, everyone. As you know, in rheumatology, it's all clinical diagnosis, but along with laboratory workup, imaging workup is also very, very important. For rheumatological diagnosis, the most important thing is the patient's symptoms and signs. And then we examine the patient and ask the relevant blood test and relevant imaging. In rheumatoid arthritis, how we diagnose is the symptomatology. Patient will have symmetrical polyarthritis. Usually it starts in the small joints of the hands and feet. Occasionally it may involve large joints to begin with, but classically rheumatoid starts in the small joints of the hands and feet. The duration should be more than 6 weeks because there are mimickers like chikungunya. For example, if you see a case following a viral fever like chikungunya and order tests like rheumatoid factor, it can be false positive. So we end up over-diagnosing the case. So ideally, the symptomatology should be more than 6 weeks. The patient should have symmetrical polyarthritis, symmetrical, as you know, involving both sides of the body. And on the laboratory workup, you see positive rheumatoid factor, positive CCP, and ESR CRP will be high. For all new patients, we always ask for radiographs of the involved joints. And within few months, we may not expect the radiological signs, but usually it will guide us for future because the baseline X-rays are very important. And of late, we have been doing lots of high-resolution ultrasound. Whenever we have a doubt and patient's symptoms are not very clear, and on examination there is no synovitis evidently, then nowadays we are asking for high-resolution ultrasound to pick up early rheumatoid arthritis. So these are my inputs as a rheumatologist. Now I'll request Dr. Pallavi to start her lecture.
Hello everyone. I hope you all can see my screen.
Yeah, you can go ahead, Pallavi. Yeah, we are able to
Yeah.
see your screen.
Yes, sir. First, I would like to thank Dr. Chandra Mouli, sir, for concerning to be our chief guest for today's session, to giving his for giving his valuable insights for the topic and the clinical perspective for the disease. I would also like to thank Dr. L.T. Kishore, sir, and Krishna sir, for giving me the opportunity to discuss the topic. Rheumatoid arthritis is a common chronic systemic inflammatory condition characterized by proliferative synovitis and inflammatory arthritis. It usually affects 1% of the world's population. Women are more common, 2 to 3 times more commonly affected than men. The peak age of onset between being the 45 to 65 years of age. It has a genetic predisposition with 70% of patients being HLA-DR4 positive. It is bilateral and symmetrical, as Sir has said. It involves predominantly the small joints of hands and feet. It's the characteristic of the rheumatoid arthritis patients with predominant involvement of the metacarpophalangeal joints and hand, proximal interphalangeal joints, and the wrist. Synovial inflammation and proliferation is the primary pathologic process resulting into marginal erosions at the bare areas in the involved joints that which progresses centrally. The cartilage loss loss causes symmetric joint space narrowing, and if the disease is untreated or inadequately treated, it leads to fibrous and osseous ankylosis. The ligamentous laxity and the rupture leads to subluxation and dislocation of the joints. With the disease progression, the adjacent structures such as tendon sheath, tendons, and the bursae are frequently involved. Prompt diagnosis and appropriate treatment are the essential components for improving the clinical outcome in patients with early rheumatoid arthritis. While imaging of rheumatoid arthritis, as because of the feasibility of conventional radiology, it is widely used, but it lacks in early detection of erosive disease and inability to detect the synovial inflammation. MRI has greater sensitivity for detection of synovitis and articular erosions, which helps in establishing early diagnosis. The primary advantage being its possibility to visualize the bone marrow abnormality. It doesn't involve ionizing radiation, that's why it is also safe in pregnancy. But the limitations are like long time examination, high cost, and its lower availability. The adverse contrast agent reactions and contraindications like claustrophobia, metallic implants. Ultrasound is an extension of the clinical examination in real time. It does not involve ionizing radiations and is safe during pregnancy. It's a powerful diagnostic tool in detection of early or radiographically occult articular erosions and allow differentiation of active disease from the disease remission. To identify the soft tissue rheumatoid nodules, it also helps. The drawback of ultrasound is it is operator dependent and cannot penetrate the bones, and poor resolution for deep-seated joints. So in the imaging findings of rheumatoid arthritis, we will discuss about articular erosions in rheumatoid arthritis. As per 2010 ACR and EULR RA classification criteria, erosive disease is diagnosed when an erosion is seen in at least 3 separate joints involving the proximal interphalangeal joints or metacarpophalangeal joints or wrist, which is counted as a one joint, and the metatarsophalangeal joints. It shows erosive changes in early disease, which leads in the aggressive disease. The presence of erosions in early disease, as well as their progression in size and or number, are poor prognostic indicators. Conventional radiography is most commonly used in clinical practice for detecting erosions in rheumatoid arthritis despite its low sensitivity. Ultrasound is useful in detecting erosion in patients with early stages of disease. Erosions that are detected on ultrasound or MR imaging progresses to radiographic detection in the majority rheumatoid arthritis cases within 1 to 2 years. This is an ultrasound image on the left which shows an cortical interruption, which is an erosion all along the dorsal aspect of the second metacarpal head, consistent with the erosion in the bare area. While these are the two MR images, T1 weighted coronal image and a stir coronal image, which shows articular erosions, which is seen on ultrasound at the second metacarpal head and the radial and the ulnar aspect of the third metacarpal head. Synovitis in rheumatoid arthritis occurs early in the natural history of rheumatoid arthritis. hyperemia is the first step in the inflammatory cascade, can be identified with imaging, including the color Doppler or power Doppler ultrasound. Recent studies have shown that no bone damage occurs in the absence of synovitis, that the presence of synovitis is a prognostic indicator of the bone damage, thus stressing the importance of early assessment of synovitis. Power Doppler ultrasound demonstrates high specificity than contrast-enhanced MR imaging and almost the same degree of sensitivity for diagnosis of early inflammatory arthritis. Doppler ultrasound plays an important role in evaluation and monitoring of the patients with inflammatory arthritis in clinical practice and clinical trials. So the ultrasound image on the right shows a complex joint effusion with a peripheral power Doppler uptake, which is seen in synovitis, while this MR image on the left shows it's a T1 post-contrast MR axial image, which shows mid-carpal synovitis, flexor tendon tenosynovitis, and the fourth extensor compartment tenosynovitis. Bursitis is also, it's not a common finding in rheumatoid arthritis patients with early presentation. It rarely seen in hands, but other locations which are included in bursitis are Achilles tendon, bursitis, subacromial bursitis, olecranon bursitis, and gluteus maximus bursitis. Bone marrow edema is also one of the presentations. The ability to image bone marrow edema is an advantage of MRI over ultrasound and radiography. Bone marrow edema is seen as an hyperintensity 2 signal within the trabecular bone, which has ill-defined margins. The differential diagnosis for this is intraosseous cyst, which is better delineated and represent areas of damaged bone, which is easily seen on plain radiography as compared to the bone marrow edema. In rheumatoid arthritis patients with active disease, power Doppler and color Doppler ultrasound allows differentiation between joint effusion and synovitis, active or inactive synovial proliferations, tendon sheath and bursal effusion for synovial hypertrophy with or without active inflammation with associated hyperemia. According to ESSR and EULR recommendations, MRI is currently considered the best and non-invasive independent imaging modality to evaluate inflammation of the joints, tendons, entheses, and bone marrow. The main indications for MRI in patients with rheumatoid arthritis include assessing the inflammatory lesions that are not detected on clinical examination, assessing early signs of inflammation such as synovitis, tenosynovitis, bursitis, bone marrow edema, and establishing the prognosis, including synovitis, bone marrow edema in particular, are risk factors for the progression to the structural changes, assessing treatment response and monitoring disease activity and progression, assessing remission, identification of disease complication. Ultrasound is commonly performed to evaluate patients in evaluate peripheral joints, tendon sheaths, and the bursa in rheumatoid arthritis patients due to its availability and low cost. The main indications for ultrasound include assessment of inflammatory lesions that are not detected on clinical examination, assessment of early signs of inflammation including synovitis, tenosynovitis, bursitis, assessment of treatment response or monitoring disease activity and progression, assessment of remission, identification of disease complications in peripheral joints. While discussing the differential diagnosis, first I would like to discuss crystalline arthropathies, which include gouty arthropathy and the crystalline phosphate deposition arthropathy. So gout is an ancient metabolic disease with genetic predisposition. It results from monosodium urate crystal deposition in and around the joint secondary to long-standing hyperuricemia. It causes recurrent attacks of acute arthritis and may lead to chronic arthropathy, topher deposition, and renal disease. Acute gouty arthritis often begins in the lower limb joints, frequently the metatarsophalangeal joint, which is termed as podagra. The other frequent locations are tarsal joints, ankles, knees, which is followed by elbow and the hands. It presents with pain, swelling, and erythema of the affected joint. Tophaceous gout, 30% of the untreated patients develop tophaceous gout within 5 years. Tophi can occur anywhere throughout the musculoskeletal system, frequently developing about joints, tendons, and bursae. Typical tendon targets include Achilles tendon, knee extensor mechanism, and popliteal tendon. The bone erosions produced by tophaceous deposits are intra-articular, para-articular, or distant from the involved joint. While discussing the gouty arthropathy high-resolution findings, in gouty arthropathy, The monosodium urate crystals deposit on the surface of the hyaline cartilage, resulting into appearance of a hyperechoic line at the outer margin of the hyaline cartilage, which is termed as double contour cartilage line, seen in patients with acute gout flares or a history of prior gout attack, or in an asymptomatic hyperuremic patient. Tophi appear as a inhomogeneous hypo to hyperechoic appearance surrounded by a thin anechoic rim, seen in all metatarsophalangeal joints and metacarpophalangeal joints in a gout patients. The erosions and are also show erosions adjacent to the tophaceous material. The distended joints will show a finding of anechoic synovial fluid or mobile hyperechoic stippled aggregates, which creates a snowstorm appearance. In chronic gout, the radiograph usually shows a classic punched out periarticular erosion with overhanging edges, periarticular hyperdense soft tissue swelling due to tophi. An ultrasound is more sensitive than radiography for diagnosing erosions, but can underestimate the extent and the number of erosions as compared to MR imaging. However, the presence of readily identifiable synovitis and tophi increases the specificity of ultrasound in diagnosing the erosions. Gouty erosions are deeper and much more destructive as compared to rheumatoid arthritis erosions. Crystal deposition may also occur in periarticular soft tissue, tendons, and bursae. Ultrasound also may show echogenic hard tophi or sonolucent soft tophi. Dual energy CT scan is a non-invasive method of urate crystal detection that can make the joint aspiration unnecessary in gout patients. Dual energy CT scan simultaneously scans the subject at two different energy levels. Because the urate crystals show different attenuation at these energy levels, the crystals can easily be identified with high accuracy. So it is useful when the findings are not so typical, and also very useful to show the extent of the disease. The CPPD arthropathy is caused by deposition of calcium pyrophosphate dihydrate crystals in articular and periarticular tissues. Chondrocalcinosis is the presence of intraarticular calcification with involvement of the hyaline articular and fibrocartilage. It is most common sites of involvement being knee, wrist, and the hand. In the wrist, it typically shows triangular fibrocartilage and about the proximal carpal low joints. In hand, the second and third metacarpophalangeal joints with chondrocalcinosis is common. The next joints involved are the pubic symphysis and the hip joints. Radiography should be the first imaging modality used in diagnosis of CPPD, but because of its sensitivity of detection of chondrocalcinosis is as low as 40%. The image on the ultrasound shows the crystals are aggregated in the middle layer of the hyaline cartilage parallel to the bony cortex, which appear as a hyperechoic irregular dotted foci or a line of variable length embedded in the anechoic appearance of the appearing hyaline cartilage with normal hyaline cartilage surface. The calcifications of the on X-ray, the calcification of the triangular fibrocartilage as well as the scaphoid unit ligament and lunotriquetral ligament can also be identified. The different patterns of crystal deposition in gout and CPPD arthropathy allow differentiation of these two metabolic arthropathies with ultrasound. The deposition in the fibrocartilage in CPPD, such as triangular fibrocartilage of the wrist and menisci, appear as a round and amorphous hyperechoic foci. While discussing the differentials for rheumatoid arthritis, spondyloarthritis is an important topic to be discussed, which comprises a group of inflammatory diseases of the joints and spine with various clinical manifestations. They have some key features in common, which include joint inflammation, especially the sacroiliac joints, enthesitis, especially in the lumbar spine, HLA-B27 genetic factor association, and seronegativity, which is rheumatoid factor negative. They are grouped into divided into two groups, which is axial spondyloarthritis and the peripheral spondyloarthritis. Axial spondyloarthritis include ankylosing spondylitis, and the peripheral include the psoriatic and the reactive and IBD associated spondyloarthropathies. SAS classification criteria for spondyloarthritis is a criteria which is used to which helps in differentiation and coming to a conclusion. In this, in patients with more than 3 months of back pain and age of onset less than 45 years, if the patient is A patient shows sacroiliitis on imaging plus more than one feature of spondyloarthritis features, or an HLA-B27 positive with more than two spondyloarthritis features. It is helpful in axial spondyloarthropathies. The spondyloarthropathy features in axial spondyloarthropathies are inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, psoriasis, Crohn's, colitis, good response to NSAIDs, and family history of spondyloarthropathy, HLA-B27 and elevated CRP. While in patients with the peripheral spondyloarthritis, in patients with peripheral symptoms only, the criteria includes arthritis or enthesitis or dactylitis plus more than one feature of spondyloarthropathy, which includes uveitis, psoriasis, Crohn's or colitis, preceding infection, HLA-B27 positive, and sacroiliitis on imaging, or more than two other spondyloarthritic features, which include enthesitis, arthritis, dactylitis, IB, inflammatory bowel pathology, and family history of spondyloarthritis. While discussing the seronegative spondyloarthropathy, which includes psoriatic arthritis and reactive arthritis, that frequently involve the small joints of the hand and feet, it has high association with HLA-B27. Psoriatic arthritis is an enthesial disease with secondary joint involvement. It is seen in 10 to 15% patients with psoriasis in a predominantly asymmetric distribution. The age of onset being 30 to 50 years with equal gender distribution. It also involves spine, sacroiliac joints, peripheral joints and or enthesis. The joint damage manifests as erosive changes or as well as periarticular new bone formation. The periarticular new bone formation may eventually lead to ivory phalanx and bony ankylosis, which is easily diagnosed on radiographs. It can be monoarthritic or polyarthritic. It may present as a mild to severely destructive disease as arthritis mutilans. Distal phalangeal tuft resorption is a characteristic but non-specific finding of psoriatic arthritis. Classical sausage digit due to dactylitis is seen due to flexor tendon synovitis being the process leading to the dactylitis. Reactive arthritis is a non-infectious asymmetric inflammatory oligoarthropathy characterized by a triad of arthritis, urethritis, and conjunctivitis. It usually is triggered by enteric and urogenital infection. It has predilection for the lower extremity joints. The pattern of involvement usually is enthesitis, joint effusion, synovitis, bursitis, erosive and proliferative, as well as diffuse soft tissue edema accompanied by finger and toe tenosynovitis. It is frequently indistinguishable, and the specific diagnosis is usually made based on the clinical grounds and the disease distribution. While discussing the high-resolution findings, the features include synovitis, joint effusion, bone erosions, as well as extra-articular findings such as bursitis, tenosynovitis, and enthesitis. Asymmetric joint distribution distinguishes psoriatic arthritis from the typically bilateral symmetric rheumatoid arthritis, as well as the predominant involvement of the synovitis in distal interphalangeal joints compared with the rheumatoid arthritis patients. Ultrasound, MR imaging, and scintigraphy have higher sensitivity in detection of oral joint disease than radiography in painful and swollen joints or clinically unaffected joints. Radiography was earlier superior to ultrasound in visualization of proliferative bony changes. Joint diffusion and tenosynovitis are more frequently detected with MRI than ultrasound. In symptomatic enthesitis, the presence of Doppler signal about the enthesis appears to offer greater specificity for inflammatory mediated disease. Peritoneal inflammation associated with extensor tendon hypoechogenicity, the adjacent edema, and increased power Doppler signal at the enthesis in psoriatic patients may be differentiating feature of psoriatic arthritis from rheumatoid arthritis. Osteoarthritis is the most common arthropathy resulting from repetitive articular cartilage damage. It is diagnosed usually based on the clinical findings and the radiographs, especially in advanced stages. It results in non-uniform joint space narrowing with osteophytes, most often in weight-bearing joints, and does not involve erosions. MR imaging is superior to ultrasound as it allows complete visualization of the articular cartilage and can depict bone marrow edema. Ultrasound may show features of peripheral marginal osteophytes, which is depicted as the step-up prominence of the cortex due to new bone formation. Joint space narrowing can be seen, particularly if marginal and it is severe. Effusion and tenosynovitis at ultrasound associated with Doppler flow also can be seen. In patients with coexistent erosive and degenerative arthropathies, the cause of inflammation may be difficult to determine. So the take-home message is, if the uncontrolled rheumatoid arthritis disease leads to joint destruction, functional disability, decreased quality of life, cardiopulmonary complications, and shortened lifespan. The outcome of the patients with rheumatoid arthritis have been revolutionized by early diagnosis and aggressive treatment strategy based on the treat to target approach. Currently, the therapy aims to achieve clinical remission. With the development of effective targeted therapies, future ambitions will be either to prevent rheumatoid arthritis or to achieve a drug-free remission, which effectively will cure. All these are only possible if we can identify the robust predictors for progressive disease in at-risk individuals and intervene early. Thank you.
Yeah, thank you, Pallavi, for a lucid and informative talk. I invite Dr. Sarath sir for his comments.
Now, it's a wonderful lecture. You covered all
Yeah.
essential diagnosis, not only RA, you covered up to gout also, gout and osteoarthritis, psoriatic arthritis, ankylosing. Nothing to add from my side. But nowadays we need many more radiologists who are interested in MSK.
Yes.
I've been associated with Dr. Krishna for more than 20 years.
Yeah. Yeah, I learned through you, sir, most of the things. So we did so many cases related to ultrasound as well as MRI, uh, differentiating spondyloarthritis as well as rheumatoid arthritis, all these cases. So yeah, ultrasound really plays a key role in diagnosing these synovial disorders, and MRI is very useful for detection of sacroiliitis in case of spondyloarthritis, as well as enthesitis, as well as the spinal involvement in case of spondyloarthritis. For these cases, definitely MRI is very, very useful, as well as detection of the bone destruction in case of monoarthritis. Definitely MRI is useful to distinguish for infective arthritis from inflammatory arthritis. Yeah. So, and gout especially, we want to tell about dual energy CT scan. Recently we have a dual energy CT scan that can tell about the monosodium urate crystals in the soft tissues as well as the joints. If you do the whole body or specific joints, it will confirm that these are monosodium urate crystals.
We'll start sending the cases to you.
Yeah, that is really very, very useful investigation to diagnose these cases. Yeah. So
we have a problem with the ultrasound scanning because not everyone is well trained. So lots of places where they have ultrasound machine, and because of lack of training, they actually overdiagnose rheumatoid on ultrasound. So unnecessary diagnosis and unnecessary medication is happening. So you people should try more more radiologists and rheumatologists, because I think in future the rheumatologists, the MSK ultrasound is going to be a stethoscope.
Yes.
Yeah.
All the new rheumatologists are.
Yeah, definitely. Yeah, the ultrasound is useful in the early diagnosis as well as in the detection of the progression of the disease or a treatment response. And for all these things, definitely ultrasound is very, very useful. So I think more and more radiologists have to start doing these cases, so that it is definitely helpful for the rheumatologists to treat their cases. Definitely, because we are availability of so many radiologists, so we can definitely use their services for this kind of disorders rather than.
Okay, thank you very much.
Yeah.
Okay.
Yeah. Thank you. Thank you.
Thank you.
Thank you.
Thank you,
so
sir.
much.
Bye bye.
Bye. Bye.
Yeah.